Yeah, we are recording. Uh, Ron, thank you for being here. It's our third international webinar offered by our group Estudos, Núcleo EAE. I'm going to present Ron, just a small text, and then he can start his presentation. Um, Dr. Rhone D'Errico is a doctor of nursing practice. He's a certified as a nurse practitioner in three areas: family health, psychiatry, mental health, and emergency care. He has worked as a registered nurse in a neonatal intensive care unit and as a nurse practitioner in mental health, primary care, college health, and in emergency department. Dr. D'Errico is also a certified nurse educator. He has experience as a teacher, a clinical leader, and a healthcare executive. He's currently in an associate professor at the Rasmussen University School of Nursing. In addition to teaching, Dr. D'Errico provides telepsychiatry services for two places: a local outpatient mental health clinic and a rural inpatient and residential drug treatment program with more than 120 beds. Please, Ron, presenting us substance use disorder and American perspective. Thank you.
Well, thank you so much, and thank you all for having me. This is a true pleasure, and really is an honor to get to present to this group. I know we've had lots of members of your group come and present to us at the American Daseinsanalytic Institute, and having that interaction has been wonderful. So this is really a true pleasure to get to come and speak to you today, and hope we can get you a little, little pop-ups, get you some value out of this right now. So I'm going to be speaking briefly. I watched Tamash's video that he did before, Dr. Fazekas, and I'd really like to channel what he said, where I really view this as much more as a seminar. You are all esteemed colleagues and professionals, and I don't want to sit here and lecture to you. I prepared a little bit of talk. I just put some slides together, so we will have a short talk, but it's not going to take the entire 2 hours. I want to speak briefly, just kind of talk about the American perspective on substance use disorder. And then I really want this to be a conversation. I really want to discuss with you, get your insights, answer any questions you have. Just to start with, realizing that the nurse practitioner may be, it's an international concept, but it kind of is instantiated in different ways around the world. So I did a little research, and there's actually been some good presentations about advanced practice nursing in Brazil. So I know it exists and it is a movement, but not everybody may be really familiar with it. So in the model here in the United States, a nurse practitioner, which is what I am, and we use the terms advanced practice nurse, advanced practice registered nurse, or nurse practitioner pretty much equivalently. There's some nuances there, but for purposes of this, we can keep it kind of simple. As a nurse practitioner, advanced practice nurse, I provide the full spectrum of care to my patients. And, as Roberto mentioned, I am certified in 3 areas. I'm certified in family practice, in emergency, and in psychiatric mental health. I currently work primarily in psychiatric mental health. And what I do is I do full psychiatric assessments on my patients. I provide brief psychotherapy. I prescribe psychotropic medications. I follow their lab work. So I perform the full spectrum of care on my patients. I am a registered nurse. So I got my degree and became a registered nurse. And then I got some further education, got a master's degree and eventually a doctorate to become certified as a nurse practitioner. So I just wanted to introduce that a little bit, because I know for international audiences, that may be kind of a new term or something that isn't regularly seen or in practice around the world. I just watched a really interesting presentation that some colleagues here in the US did. There's a nurse professional who actually goes to Brazil and is working on developing advanced practice nursing in your country. So I saw that is in practice. So you might be seeing that more and more. All right, so moving on, and I do want to say, please, if anybody ever has any questions, anything comes up, just feel free to interrupt. Like I said, I don't intend this to be a real formal, long lecture. I want this to be more of a discussion and use these slides more of a jumping off point than as a formal talk. So we will get started. I'm gonna have a little my tea. All right, please let me know if the slides don't advance. So we're just going to talk about substance use disorder, an American perspective, U.S. perspective, of course. I mean, we're all in the Americas here, so this is kind of my own United States perspective. And just a little bit of history. I don't want to bog us down on this too much, but it seems like there is anthropological evidence that early hominids, our oldest ancestors, might have sought out intoxicating substances in nature. So this may have been in the context of foraging for food, and you eat something a little funny and you get sort of a funny feeling out of it. And that is at least one theory of how addiction may have started in our oldest ancestors. There's been some anthropological evidence of what they call the drunken monkey hypothesis. This is where there was an evolutionary attraction to ethanol, to alcohol, naturally fermenting fruits, producing ethanol, and then producing the effects from alcohol that we know about. There's definitely some evidence of psychoactive plant use in shamanic and healing rituals in early humans. And we have addiction as this biologically ancient susceptibility to pleasure and pain relief. So this is very, very part of the core of our humanity, or even just as being, biological life forms, as being mammals. You can see this, and they've seen it in elephants, actually, seeking out plants that have healing properties. So this really does seem to be part and parcel of us as biological beings. Moving forward, so, we're kind of doing the world tour here. So moving forward from our ancient roots to our, more near ancient roots, there was beer, opium, and religious rituals use in Mesopotamia. We see evidence of opium, hemp, beer, and medicinal papyri, meaning like there was actually textbooks on the use of medicinal herbs in ancient Egypt. Likewise, in ancient India, that we have texts on the use of herbal medicines for medicine, but also for what we would consider today for euphoric effects. So this is the use of the drink called soma in the Veda, in the ancient Indian religious texts, that we don't know exactly what it was, but there's lots of theories about what was in that drink, but it was some sort of hallucinogen or opiate or something along those lines. We have evidence from ancient China that cannabis and alcohol were used for medicine and for ceremonial reasons. Moving forward into what we call the Axial Age. So this was the era, the first 500 years BC. So pretty much 600 BC, roughly to 100, 200 BC. It kind of depends on what source you use. The psychiatrist and philosopher Karl Jaspers actually came up with this term. And it seems that across the world at around this time frame, in multiple different cultures in the East and the West. So we're talking about ancient Greece, Rome, China, India, Mesoamerica, the Americas. Right around this time, there was just this real shift in philosophy and mindset and technology. A lot of things were going in these unconnected areas. So it's a very interesting subject in and of itself. But at this point, I kind of pulled this out because it's interesting where we start to see this mind shift regarding addiction, involving the use of substances, involving intoxication, right? So we start to see, in India, the earliest in Buddhism, we're seeing craving as a root of suffering. So actually the very heart of Buddhism is craving as the cause of dukkha, of suffering, and that separation from suffering is the way to enlightenment. Likewise, in China around this time, Confucianism and Taoism were really stressing balance and restraint, staying in balance with nature, especially with Taoism, and then Confucianism stressing really restraint and social, maintaining those social boundaries as well. Ancient Greece around this time, or Axial Age Greece, is starting to really get into reason over appetite. So Stoicism was emphasizing discipline. Even Epicureanism, which in modern day we tend to think of big Epicurean feasts and overeating, but Epicureanism actually in Greece at that time in philosophy was actually restraint. It was a philosophy of restraint. It was enjoying these things in life at a measured, reasonable level. So at this point, again, around the world, we're getting this kind of shift from a medicinal use of plants and herbs and medicines that can cause these euphoric or addictive effects, to now a mindset of some degree of restraint and really a moral approach to the subject. In the Persian and the Hebrew traditions around this time, substance misuse was a betrayal of the moral duty, right? You had a moral responsibility to your community, and being intoxicated or misusing substance was a betrayal of that duty. Now, as we transition into modernity, right? So we're taking big leaps in history. So I could have broken this down a lot nearer, but I didn't want to turn this into a 2-hour history lesson. But as we move into, out of that axial age into the medieval period, the Renaissance, the Enlightenment, I'm kind of collapsing all this time, but we start to really interpret addiction through science, through medicine. So science, something that can be studied, medicine, something we can treat, and law, something we can regulate, right? And that carries through to today. So this is really where we are at in modern addiction treatment. We look at it as something to study, a science. We look at it as something to treat, like what I do as my day-to-day work. And then we approach it as something to regulate, or a law. So this has to do with our criminal justice system. It has to do with what folks are allowed to do. Part of my practice, and we'll talk about this later, but part of my clinical practice, I actually provide telepsychiatry to a residential drug treatment program for pregnant and parenting women. So these are women that are not technically forced, but they go into treatment in order to get their children back. So their children may have been taken away by the state because of their drug addiction, and they have to go through this mandatory program in order to be eligible to have their children returned to them. So this is law really interacting with the subject of addiction in a very, very real way. In the United States, in our colonial era, so 1776, our country, the Declaration of Independence, etc. So in those early eras in the 18th and 19th century, alcohol was very normalized, but it was morally condemned. Our temperance movement really pushed abstinence as virtue. And if you look back in the history of my country, when we look back and we look at temperance and abstinence all this way leading up to what we call prohibition, which was in the 1920s, where alcohol was actually illegal in the United States of America for a 10-year period in the 20s, early 30s, by constitutional amendment. So it was a law across the entire country here in the United States. And when we look back, we think, boy, that seems a little bit extreme. But if you actually look at what alcohol consumption was like in the 18th and 19th centuries in the United States, and I'm sure this was probably pretty generalizable, the amount of alcohol that was consumed by men, women, and children from the minute they woke up in the morning to the second they went to bed was enormous compared to today. It was every day. Water was considered unsafe. So everybody was drinking alcohol. Everybody was drinking beer or wine or spirits. So that is where this temperance movement came out of, because so many people were spending most of the day drunk. And you can imagine accidents, domestic violence, kind of the downstream effects of having pretty much everybody in your culture constantly on alcohol. So that is where those temperance and abstinence movements came out of. But then it really became a view of virtue, right? When we look at those going all the way back to Aristotle in the ancient world, of virtue being this inborn moral category or characteristic of the good person being virtuous. And when you tie that virtuous to avoiding these substances, that makes people who use the substance, by definition, not virtuous. And so you get this moral element coming in. We do see, and as we're moving forward in time and we're coming through the 19th, 20th century, we're seeing opium and morphine more widely used. And then we start seeing addiction, especially when we go to that law piece, through very racialized and gendered lenses of what substances were considered good or bad was very much determined by the class of the person that was using them. So there wasn't any science or logic behind it. It was just certain substances would be associated with certain persons in the society who had less power, who were lower down on that class scale, and that kind of fueled discrimination against those classes. And I'm not going to really, I don't want to kind of go into all the laws here, because you guys don't need an overview 20th century US law on addiction, but basically this is the time in America. I mentioned prohibition, 1920 to 1933. This was the time in the United States where the legal system really started getting involved. And prior to 1914, the Harrison Narcotics Act, it was free game. Anybody could use any substance. You will see the cough syrup bottles. You can find the pictures online where they basically contained alcohol and cocaine and cannabis. And this was the cough syrup you gave to your kids, right? This is what was widely sold, and there was no regulation whatsoever. So in 1914, they start to do a little bit of criminalization. Alcohol is banned in prohibition. And then as we move forward in time, there's more and more legal impositions upon the use of substances. Now, as we get to the late 20th century here in the US, we start to see the rise of recognizing substance use disorder or addiction as a problem, right? And at this point, addiction starts to be seen in some quarters as a sort of spiritual disease, right? So this is Alcoholics Anonymous, Narcotics Anonymous, the 12-step programs. Simultaneously, so as we're getting to the mid-20th century, our president, Richard Nixon, initiated the war on drugs. So that's literally what it was called. It was political legal movement, but the war on drugs. So this was criminalization. So this was incarceration. This was much less of a focus on treatment and more of a focus on criminalizing, locking these people up. If you use drugs, we'll lock you up, and that'll prevent people from using drugs because they'll know they'll go to jail. Well, as we know now, that just doesn't work. That's not the way it works. And so, and we are still dealing with the tradition, the history, the heritage of the war on drugs here in the United States of America. And I was doing a little bit of research on Brazil and the Brazilian approach to substance use disorder as well. And I saw that that is also kind of the mindset in Brazil. There's a strong push towards criminalization, just like in the United States. I don't see any, significant difference between the two. It's that same kind of approach where you're focusing on treatment, but there's still a lot of folks in jail for substance use disorder. So we start to see, again, I mentioned some of those racial disparities based on the type of substance. So the example here is in terms of sentencing laws, where crack cocaine was much more prevalent in the Black or African American community. Powder cocaine, so essentially the same substance, just in a different formulation. Powder cocaine was much more prevalent among the white and tending to be the more upper class, higher income populations. And when you look at how the sentencing laws were written for drug possession, the drug possession laws for crack cocaine were much, much, much harsher, and still are to this day, to my knowledge, than they are for powder cocaine. So this is a differential sentencing that really breaks down to being about race in the end, because if one formulation is more popular or more prevalent among one group and you punish that formulation, by definition, you're punishing that group, right? So at the same time, in late 20th century America, we start to see this brain disease model, right? So we get the decade of the brain in the 90s. We see all these advances in neurology and neuroscience. We start getting some evidence of the neurobiological aspects of addiction. So this is gaining traction, and it's starting to be popularized. It didn't end stigma, and honestly, when you really look at things, the brain disease model that was pushed so hard, and still is to an extent today, for all the right reasons. In many ways, people really thought this would reduce the stigma against substance use disorder or addiction. It just hasn't. It hasn't worked out that way. And especially those of us that take more of an existential or psychodynamic approach to the human mind, to the human condition, recognize that just reducing everything to brain biology doesn't necessarily help people. It doesn't necessarily solve the problem you're trying to solve. It does not necessarily enhance human freedom and wellness. So the brain disease model has a lot of issues of its own. So now we move forward into the 20th century. Now we're in our own days, and this is the structure under which I work. So as Roberto mentioned in the beginning, my primary clinical work is providing telepsychiatry. So I provide psychiatry over a screen, just like this, to both a local outpatient clinic that does, it's not fully substance use disorder. A lot of it is general psychiatry, but there's a lot of folks that are in early recovery from substance use disorder. But the other part of my clinical practice is telepsychiatry for a very large rural, meaning out in the country, substance use disorder program. And these are folks that, being out in the country, don't get a lot of services. So we call it underserved. So it's very hard for them to get quality medical care, psychiatric care, substance use disorder care. This center has been there for decades, and they do excellent work. They do fantastic work in that community. So that that is the treatment center under which I work, and I am taking care of these clients, and we are seeing the opioid epidemic. So this is the misuse of prescription medications. So those prescription opiate medications, the OxyContin, the oxycodone, et cetera, that was heavily marketed in the 90s and early 2000s, leading to widespread addiction to opioid drugs. And when those drugs became hard to get, people switched to fentanyl, which is a much more potent, a much more lethal, and a much more easily available form of opioids. So switching gears a little bit. So we kind of got the history, and like I said, I definitely didn't want that to turn into just a pure history lesson about the history of substance use disorder, but I wanted to frame kind of where we are today. And our interest, I would assume, kind of knowing this group and knowing what folks are interested in, is what are those philosophical and psychological views on addiction? How have those of us that primarily try to care for the human mind, for the human being, how do we approach this subject? And just, this is a very quick overview, but broadly speaking, psychoanalysis viewing addiction as a repetition compulsion or a symptom of unresolved pain. So trying to fill some need, most likely from childhood or early development, right? That's the psychoanalytic, generally starting point. I'm sure there's a lot more nuance to it, but that's just kind of one aspect of how psychoanalysis or psychodynamic approaches may look at substance use disorder or addiction. Carl Jung. So Carl Jung was very, very deeply involved in this subject by way of having been one of the key inspirations behind Alcoholics Anonymous. And Bill Wilson, one of the founders of Alcoholics Anonymous, actually corresponded with Jung, and their correspondence is fascinating. Actually, he, very late in Jung's life, Bill Wilson wrote a letter to Jung saying, basically, you were the inspiration behind AA. They had corresponded earlier as well. And apparently Jung wrote back a very, very long missive, a long response, fully supporting and fully endorsing the Alcoholics Anonymous approach. Jung really believed that addiction was a spiritual crisis of sorts. It was a craving for transcendence, a craving for something more. And he said something along the lines of, and I'll paraphrase, but at one point Jung said that you had to do higher spirits over lower spirits. And the lower spirits is a bit of a pun because English spirits can mean alcohol. So especially like distilled alcohol, like hard alcohol, an older fashioned term for that would be spirits. So what Jung was saying is the higher spirit, sort of that spiritual aspect, was needed to overcome those lower spirits, alcohol. As we move kind of farther into mid-20th century psychology, we of course have behaviorism, especially in the United States. The 1950s with John Watson and B.F. Skinner, behaviorism became, radical behaviorism became the primary, paradigm behind psychology in the mid-20th century, and that bled into addiction treatment as well. So it is basically the study of learned behavior, of predictable responses to stimuli, right? So starting all the way with Pavlov and then moving through Watson and Skinner and all of their cohort. And so we started to approach behaviorism or addiction through that behaviorist lens. Behaviorism is a very powerful model, but behaviorism is very predictive and it is very usable in many settings. I think those of us that do have more of an existential standpoint recognize that behaviorism kind of goes so far and can go no further because it really does not address those existential ideas of freedom, of being itself, of ontology, but it is very good for predicting and controlling behavior in the day-to-day. That's been purely proven. That's clear. And then in terms of existentialism, we can look at this a bunch of different ways, but you can look at it as, angst, anxiety as one of the core existentials of human existence, like just based on the fact that we are mortal beings, that we know we can get sick, we can get hurt, and we're all going to die. So existentialism goes right for that angst as one of our fundamental components. And so an existential view of addiction can be that it is an attempted escape from that angst. It also has to do with choice. So existentialism, we're very interested in freedom, right? How free can the human being be? And addiction is really, really tied into that concept of freedom, right? On both sides. There is, should the human being have the freedom to indulge whatever substance they want and get those effects from that substance? With also, in terms of freedom, that addiction pretty much by definition takes away freedom. It induces compulsion. And when you talk to people that are recovering from substance use disorder, they will talk about how they felt they did not have freedom. They were compelled. They would use a substance without even realizing it or feeling like they had no control over their behavior. So existentially, we're looking at, well, if I try to tell someone not to use a substance, or even they tell themselves, if it's completely self-driven, they're limiting their own freedom, right? They're not free to drink as much as they want. They're not free to use as much cocaine as they want. At the same time, being a compulsive user of alcohol or cocaine or any of the addictive drugs is by definition reducing their own freedom. So how do we square that circle? It's one of the reasons I'm especially fascinated by this subject, because there's no easy answers. That's really the bottom line. If I have one summation of this subject, it's that there are no easy answers to what addiction is, how to approach it, how best to treat it, how to prevent it, how to help people. So yeah, absolutely. It is, it's a very existential concept for sure.
Ron, I don't want to interrupt you, but I want to make a question.
Sure, please, of course. This is better if people ask questions. Plus I can have some tea.
Yeah, sure. When it comes to the existential approach of addiction, and when it comes to, I've made a sort of questions to Miles, I think 2 weeks ago, and how to approach, drug and parenting without, affect the freedom, to use drugs to be themselves, I don't know, you think that behavior is a better approach of this addiction problems, or you have an opinion, I don't know.
I think that's a great question. I think it's a great question. It's really something, it's a good dialogue, especially for all of us that are in this field. And I will preface this by saying, possibly a disclaimer I should have said early on. I first of all do not consider myself an expert in existential psychotherapy, existential philosophy. I am very much a student, very much a novice in these subjects. So I do not want to present myself as someone like Miles, who actually is an expert and a published author and a scholar of existentialism. Especially the thread through Dasein analysis, through Medard Boss, through Martin Heidegger. He is an expert, right? I don't put myself in that box. I'm definitely still very much a student. I'm also not purely a psychotherapist. I am legally classified as a psychotherapist through my license, and I provide integrated and brief psychotherapies to my patients. But I also do not put myself forth as an expert psychotherapist. So I want to be very, very, very clear about that. To answer your question, It's a good question. What do you do? And that's the problem with existential therapies, right? We love existential therapies. All of us here that are really interested in human freedom and maximizing opportunity and not wanting to treat our patient like a robot, that we deliver our cognitive behavioral therapy or our behavioral therapy and just beep, boop, boop, program you. And now I'm going to program you to not be sad. I'm going to program you to not use substances. I think there's those of us that are attracted to the psychodynamic and especially the existential traditions revolt against that. We're all big on human freedom, right? And I think that's a very common thread. That's certainly where I'm coming from. The individual and freedom, the opportunity to actualize yourself is something we're very, very passionate about. That being said, to your point, you have your teenager who is using fentanyl, and you can sit them down and be as existential as you want, and they'll either call you names and leave, or they'll nod and smile and say, yeah, absolutely, I agree, and then go out and use fentanyl and eventually die, right? So what do you do? When does existentialism really hit the road where we can take that libertarian approach and say, hey, individuals are free and need to be allowed to live their own life? The Thomas Szasz approach, where he was very much pro legalizing everything because everybody should be able to make their own individual choice, and that's very attractive, and I don't argue against it. But what do you do when it's a vulnerable person or a child or a loved one? What I will say, speaking towards active addiction, so not even really getting into prevention, but if you have somebody who is active in substance use, decades of experience have shown that except for very, very rare individuals, just taking a existential or even psychodynamic approach is generally not going to be sufficient to wrest them from that addiction. Because here's where the biology comes in. I am not a biological reductionist. I'm not saying everything comes down to brain chemicals. I think humans are much more than that. But that being said, we do operate under various forces. We're all subject to the law of gravity, and we're all subject to the laws of biology. And what these drugs do to the human brain and that reward system, getting back to behaviorism, right? Those conditioned responses, that is so powerful. The drug itself, all of the social things that go around drugs. So you have all of those secondary cues in your environment. So even when you stop drugs, just, again, my patients tell me just being back on that street, seeing the people they used to use with, going back and having the same family conflicts they always did, are just powerful drivers to return to drug use. And drug use is not benign. It's devastating. It causes significant damage to lives up to and including the loss of life. And it destroys families and it damages communities. So again, circling back to your question, what we really do seem to benefit from, and that's kind of what's on this slide, is why I left it up, a wraparound approach, right? A wraparound approach, very individualized, depending on what's going on with the person. So do they benefit from some sort of medication? So MOUD is medication treatment of opioid use disorder. These are medications that we use very, very regularly. And what they are medications to kind of sit in those brain receptors where heroin or fentanyl sit. So to reduce or remove that biological need for the drug. So that's step one, is just turning off that biological signal. They don't work perfectly, but they're very helpful. Okay, so that's step one. Now, step two, we start doing psychotherapy. And some of the psychotherapy needs to be maybe a little more mechanical at this stage. Maybe these folks are not ready for an existential psychotherapy. They cannot wrestle with freedom in that way just yet. They're still too much in the grip of the addiction. So kind of more just, I don't want to say fundamental, but just more standardized, these manualized therapies like cognitive behavioral therapy, dialectical behavioral therapy, trauma-informed therapies might be needed at this stage. Like they just need, and I've learned this myself, that if you try to go too far afield, you lose them. And you might just need to come back to, okay, we're just going to do a thought record. We're going to do, paying attention to our body when we're feeling anxious, those sorts of things. So when you really need to get to that very just fundamental level, just to help folks out in that early phase. Lots of peer support. So not even true psychotherapy, peers being people that are also working on struggling with addiction, working on recovering with addiction. And what I call here on the slide, wraparound services, that just means the day-to-day stuff of where are they going to live? How are they going to get food? How are they going to get a job, especially if they have a legal record? You know, all these things. You can have all the psychotherapy in the world, but if somebody doesn't have a home to live in and a source of food and a place to keep their family safe, it's not going to do much. So we really are pushing for these integrated care models where you take everything and really get that person in a place where they have the resources they need to recover from addiction because of how severe it is. And I think at that point, if you can get all that in place, then you can really start looking at the existential questions. And then you can really look at the existential therapies and the freedoms involved. So back to teenager or a child, I think you need to just be much more interventional than existential therapies, especially like a Dasein analysis. It's just you've got to be realistic, and you've just got to understand that too much freedom at that stage is just freedom to allow someone to harm themselves. And when it's your child or your loved one, and I don't think it would be very difficult to say there's probably many people on this call right now that we all have had family members, loved ones, friends, or even ourselves who have struggled with this. And just know that when you can argue with them, you can talk philosophy with them, you can do whatever you want, but the addictive drive is so strong that you have to be more interventional in order to give folks a chance. And they're generally grateful down the line. They're like, I'm glad I had all that intervention early on, so then I could seek my freedom existentially. Did that talk around it, Roberto, or did that kind of
Yeah, sure. Yeah, you did. Thank you.
All right. Yeah. And we pretty much covered this slide, and I think I'm getting pretty close to the end of my slides. So yeah, just kind of talking about the work I do. So we'll just kind of wrap it up as we move into the discussion phase. I mentioned before, this is what I do. So, so my day job is I am a professor in a nurse practitioner program. So I work in a university and I teach graduate students who are learning to do what I do. So they're learning, they're nurses who are getting graduate degrees as psychiatric nurse practitioners. So I get to teach. That's what I love to do. That's my joy in life. So that's my primary job, is as a professor. And then in addition, a lot of times, like I think psychologists can resonate with this, because a lot of psychologists have that scientist practitioner model, right? Where you teach or you do research or something like that, but you also do clinical practice. And it's considered generally beneficial for those of us that teach to also have active clinical practice. Because as you all know, as students, or if you teach yourself, you know how valuable it is to have your teacher, especially in our field, especially once you're a graduate student, you're a professional, you're an adult. It's very nice to have that professor or that instructor say, hey, let me tell you about a patient I saw last week, because I always love that as a student. I really appreciate that when it really brings it down to earth and you know that your professor is walking the walk. So I do work in psychiatry, and my primary work is in addiction psychiatry. I manage co-occurring disorders. So sometimes I'm managing folks that are having anxiety, difficulty sleeping. So they're in the treatment setting. And I'll talk a little bit more about that just to give the American kind of the model, so you know what I'm talking about. I'll just say it right now. So we kind of have two models. We have the 28-day model. So this is where folks they've already been detoxed. So they've stopped using their substance most of the time, not always, but most of the time they've stopped using their substance for maybe a week or two. They've gone through the first level, which we call detox, which is when they're just getting off of the substance. They can't focus on anything else except getting through those first few days. Then they come to my 28-day treatment center. And this is where obviously they're still in very, very early recovery, and they're learning skills. They're kind of in a group setting. They don't have their phones. They're very restricted in their activities. They're voluntary. These are not prisoners. People can just walk away anytime they want. But if they want to complete the program, they have to follow the rules. So they're in this 28-day program, and then I provide support as telepsychiatry. Some of the folks are just like, I can't sleep, very anxious, right? Because they're coming off of their substances. It does not mean they have a psychiatric disorder. These folks do not have psychiatric illness. Not being able to sleep because you're in this treatment center and you've been off of methamphetamine for a week isn't a psychiatric disorder in my mind. That's just a symptom you're undergoing. So I will provide medication if it's appropriate and beneficial. And then the other part are sometimes folks that really do have legitimate psychiatric disorders. They have bipolar disorder, they have schizophrenia, they have severe major depressive disorder, they have obsessive compulsive disorder. So individuals that have serious psychiatric illness who also develop addictions and are in this treatment center, it's a good chance for them to actually get their psychiatric care managed or initiated or altered, so they get to see me. So that's a very rewarding part of my job, because a lot of these folks have been battling with these serious psychiatric illnesses on top of their substance use disorder, which just makes it exponentially more difficult for them to be sober. It makes it exponentially more difficult for them to navigate life. So those are kind of the groups I see. A lot of trauma, obviously, in these populations, just some very, very significant childhood and adult physical trauma, emotional trauma, sexual trauma, just a lot of that background. So I deal with a lot of that. Of course, I end up seeing a lot of personality disorders kind of coming out of that trauma background. So we see some folks with some very, very serious psychiatric issues. I generally do medication management, so I do provide prescribed medications, psychiatric medications, and I also work with the counselors, I work with the therapists, I work with the care coordinators to just make sure all aspects of the patient's care are taken care of while they're in the treatment center. I listen is honestly the biggest part of what I do in my job. The medication part is actually, in a lot of my practice, takes much of a back seat. This is part of my attraction to the existential modalities, where, as you can imagine, the way I'm talking through this, you can hear it. It seems very mechanical, right? You go through detox, then you go through 28 days and you do your classes and you can't use your substances and you got to see the psych nurse who's going to give you medications. And it's very mechanical. And I've gotten just a lot of, I would say, perceived benefit, at least I hope so, just by reinforcing to my patients, listen, I view you as a human being. I know that you've had these life events, you're struggling with addiction, but you are a free adult human being, and that's how I'm going to talk to you. And we set that basis, and then we just get to meet and just talk. And sometimes we don't do anything with medications. We just give them that free space where they can express themselves and have somebody listen to them that is non-judgmental and is honestly interested in them and their life. So that is the work I do. I also cover a 4 to 6 month residential drug treatment program, and that is for pregnant and parenting women. And again, there's a lot of existential concepts in that as well, where those women are either pregnant or they're wanting to be reunited with their children as well. Roberto, did you have a question?
Yeah, sure. And how the formation program on ADI impacts this just listening, support, and restoring dignity, that you were talking about?
Yeah, it's been very, very helpful to my work. Absolutely. And I think this is actually, I don't think I have much more in. Yeah. I'm gonna actually stop sharing because I think we've gotten to most of it. And I think the question that you ask is really good. And I would like to definitely at this point open it up. Please really invite folks to ask questions. I don't want to just simply monologue with you. I think we framed it. So ADI, so I am an analyst candidate in the American Daseinsanalytic Institute. I've been for about a year. I was very drawn to it again because of my interest in existentialism and in Heidegger and in the related subjects. And it's made a really, really big impact of I always had that viewpoint of wanting to respect the freedom and wanting to treat my patients as human beings. So that's always been there. But as you can possibly imagine, is I talk a lot, right? So I'm a talker. I have the lecture gene. I'm a professor. So I still have to really watch myself from talking at my patients, right? So I'll talk a lot. And ADI has really helped me just force myself to shut up. So I'm like, okay, I just need to be quiet and just listen. And I think ADI has been very, very helpful for that. It's been very helpful for me to think in terms of those existentials, like what just fundamental concepts of being in the world is my patient struggling with, and using that language with them, just really bringing it down, because they get so used to being medicalized, where they'll go to these classes and they'll be told about the neurotransmitters that are going on in their brain and how that drives their addiction and their trauma history and all of this. And I use those existential concepts and say, let's just bring it down to you are thrown, right? Thrownness. You're in the world. You didn't choose to be born. You didn't choose to be where you are. And to a large extent, you didn't choose where you were to be right in front of me today. To some extent, yes. And to some extent, no. And you are here. You have found yourself here. You're here and I'm here as a fellow human being. And we can use that as our starting point. And I really feel that that's very healing. I've gotten, the patients I deal with are just surprised by that viewpoint, because they're very used to being medicalized and treated as objects in their daily lives. Prior, they were often very objectified. And then when they move into the treatment setting, they're still somewhat objectified. They're somewhat treated like children because there's all these rules in the treatment center and you can't talk to people this way. One little tiny example of that is the patients will often swear, use profanity, right? Just in terms of talking. And they'll always immediately apologize, even more so than just your standard patient. And it's because they get punished in treatment if they use profanity. They're told, don't talk that way. You can't use profanity, which I understand. I'm not criticizing. You can't have, you want to set those social rules, because a lot of these folks are kind of, they're a little on edge already, and a lot of them don't have a lot of social skills to begin with coming from their background. So you get them all together. They're separated by sex. So there's all women or there's all men. I've covered both. I spend most of my time in the women's center. That's just where the need was the most. I'll occasionally cover the guys as well. But so you have all these women in a treatment center just bumping up against each other, tempers flare. So they tell them you can't swear at each other. So when they come to see me and they swear or use profanity, they immediately apologize. I'm so sorry. And as long as I'm not interrupting like an important concept, I will say, just to let you know, you can say anything you want. You can use profanity. You can use profanity at me. You can call me names, right? And you will not be punished. I will not write down that you called me this and put it in your record. I said, the only thing I am legally and morally obligated to do to talk about what we're talking about today is if I think you're an imminent risk of harming yourself or you're an imminent risk of harming someone else. Other than that, it's nobody's business what we talk about in here. I have to do a medical note. And I'll just say, I talked to the patient is sleeping better, still has some residual depression. We made these changes. And I tell the patients this, but I say, other than that, I'm not going to say you called me this, patient used this profanity, patient said this person in the treatment center is an XYZ. I say, this is a freedom. And just that little tiny, minor seeming point makes all the difference in the world. Of establishing trust and just an environment where you're not getting treated like a kid that can't say whatever word. So that's part of how I really try to take those big concepts from ADI and bring them into my treatment approach for this very specific population.
Sure. And Ron, I don't know, this is the first approach that you use to your clients, this opening, you can swear, you can talk whatever you want, or start like a more interventional, and then it seems possible to have this kind of freedom you start to use. How you approach, because we are talking about the limits of existential psychotherapy. You start by doing this, allowing people to talk whatever they want, or you start by being more interventional, and how do you switch? How do you see that existential are not sufficient, are not enough in these cases,
Yeah, that's a really good question. I will say, most all of my encounters start with a psychiatric evaluation. So the patient will be put on my schedule to be evaluated for the first time. And my approach is generally to be very conversational and to, I introduce myself, tell them kind of what my role is. I ask them their identity, just because we're on telepsych, so I want to make sure I have the right person. And then I go right into, what can I do for you? What brings you in today? I try to make it very, very open-ended. And I'm able to do that. I kind of cheat. So I have to give, in my setting, I have it very easy in some ways. One, all these patients have had to do a very detailed intake to enter the treatment center. So I get to review that ahead of time. So I get to peek and see if there's any red flags or anything I need to make sure I address at some point. And the second part is they are in treatment. They are in sort of a restricted environment. So I know that even if things are a little too free in our discussion, they're going to leave the office and they're going to go back to their residential treatment area. They're not just going out onto the street. So I have a lot of freedom in that, just to say right from the very first interview, just tell me what's on your mind. Just tell me what's going on. And then, of course, this is psychiatry. So I have to guide the discussion around here. I have to say, have you ever tried to take your own life? Have you ever cut or hurt yourself? Have you ever heard voices? But I try to mix it very much organically into the evaluation. But I really do try to start with that freedom right at the beginning, knowing that as soon as they leave my office, they're going to go someplace where they have a bed, they're in a safe space, there's staff to help them, there's staff to make sure they get their medications that are prescribed. So I'm able to be fully existential and just say, no rules, right? You can talk about anything you want. And I try to do the same way because I cover also an outpatient center locally, but that's a little different because those folks are just living their lives. So I do have to have some mindset, like, are you in a safe place? Like, are you in a place where you have a house? Are you in a place where you're at risk for domestic violence? So there's a little bit more of that aspect. But in the treatment center, I can be completely free because I know they're in a safe space.
Okay. And it's really, really nice answer. I know that you work primarily with telepsychiatry and as a professional, as a professor. And I don't know, at some point you think that you might change to design analyst? Yeah, to give design analyst.
Yeah, so that's honestly been a challenge. It's been the biggest challenge in that I know Daseinsanalysis is not really open to teletherapy. It's very focused on in-person. And I knew that coming into it. So I always want to lead with that because it's not like anybody pulled the rug out from under me. I knew going into it when I talked to Dr. Fazekas when I first entered the institute, that when it comes to the portion of like case consultation, when it comes to that aspect, it has to be in-person patients. And I don't have in-person patients. I don't have traditional therapy patients. All of mine are psychiatric patients. So it's a challenge. It's been a challenge. It's honestly kind of, I'm keeping up with the didactic, the lecture portions of the institute, but I have not moved forward on the actual in-person training aspect because I do everything over telepsychiatry. So yeah, so as of right now, I'm doing the intellectual parts, I'm doing the studies, but I feel like I'm using these concepts with my patients, but I would not claim to say that I am performing doctrinaire Dasein analysis. I do not call myself a Dasein analyst, regardless, because I haven't completed training, but still I understand that I'm not, other people in our group, they actually see patients in person, they see them on the couch, they do that, and I'm not doing that. So but I got to tell you, this is kind of my style. I'm just going to be I like taking the bits from a lot of different traditions and learning those bits and just using them in a way that is hopefully beneficial, and it's a chance for me to develop and do my job better. So I'm kind of unapologetic about it, and I don't know when that's going to change, to be honest. With my schedule and the way my life is right now, it would take a major change for me to set up an in-person treatment, like an in-person office for myself, like a private practice. So I don't know. We'll get there. But right now I'm the rogue agent. I'm the rogue telehealth teletherapist in the ADI world.
Okay. There's a question. I don't know. Here in Brazil, we have it's not an epidemic, but it starts to create a lot of problems on our practice, because most of people here are psychologists,
Okay.
it's not a design analyst. But here in Brazil, we have like a presenting a problem that's sport betting. I don't know if in
Yeah.
US are starts getting as in Brazil. But we have a question. Can you give us a little talk about bets addiction? Do you have anything that comes to your mind when?
Yeah, that's a really, really good question. And it's interesting, when I was doing my research on Brazil, I saw that came up, that I guess you guys like legalized it, I think it was 2019 or something like that. And so I'll say in the beginning, I don't think I have any brilliant insights to offer on that. I will say, so I am currently in Las Vegas, Nevada. I was born and raised in Las
And
Vegas.
you are in Vegas.
Yeah,
right?
so I am in Vegas. So I assume it's relatively world known, but Las Vegas is well known for its gambling. So this town was one of the earliest places in the United States to have legalized gambling. And for many, many decades, the only places, Reno and Las Vegas, and then Atlantic City and New Jersey, were the only places where people in the US or even from around the world could come to legally gamble. Right. So this is, and it's ironic, because I was born and raised here. My parents never gambled. No one in my family ever gambled. I had a very normal middle-class suburban upbringing, but I just happened to live in this crazy city. I worked in the casinos as a young man. I spent the first decade of my life working in hotels and casinos. Good jobs, really good jobs. So yeah, I'm definitely very close to it. And it's interesting to watch that evolution of it becoming more widespread, because the same has happened here, where it's easier for people anywhere to gamble, including sports betting, and sports betting seems to be one of the more serious forms. What I can say is there's a temptation that there's a lot of discussion about bringing in what they call behavioral addictions, non-chemical addictions, and calling them addictions. So video game addiction, internet addiction, food addiction. And there's always a lot of debate, like, is this an addiction? Is this not? I'm not going to get into that debate, but what I will say is what the research pretty clearly shows is that of those, gambling acts just like a heroin addiction. From what we can tell, it is compulsive. It is difficult to battle. It is devastating. It's usually men mostly, and you have guys that just, spend every dime. They spend their children's food money. They mortgage their home. The compulsion is really powerful, and in some ways, I think, just in my personal experience of observation, even more powerful than some of the chemical addictions. To be honest with you, the gambling addictions are brutal. They're very, very, very serious. The treatments we have tend to be the same treatments we use for, chemical addictions, for drug addictions, in terms of treating any underlying psychiatric conditions, psychotherapy to address those aspects of being that may be impeded, whether you do it through a psychodynamic standpoint or an existential standpoint, and the social support, and then the abstinence. But just like alcohol, one of the things about alcohol addiction is because it's so readily available. You can go into any store and buy a beer or wine or whatever you want. It's everywhere. And likewise, once you legalize gambling, it is also everywhere. A big part of it is people will not recognize it as an addiction. That's a big part of it. Where they will, they'll say, no, I'm not on heroin. I'm not on drugs. Gambling, it's legal. That's the new thing, right? They'll say, well, it's legal. They wouldn't have made it legal if it was dangerous. If only, right? We know that's not true. The financial interests behind sports betting are huge because the house always wins. That's the lesson of somebody who was born in Las Vegas. In the short term or the long term, the house always wins, meaning the person that's delivering the gambling is always going to win in the long run. They may lose in the short run. You may have a big win and take that money from the casino, but in the long run, they always get it back because of this addiction. We've known this. There's like a stanza in the Rig Veda from ancient India of a man who's addicted to dice, and he's praying to the gods to take the dice away from him because he cannot stop rolling the dice. So gambling, I could do a whole separate talk on I probably should because I'm a Vegas guy. I don't treat a lot about it, but it goes all the way back to those ancient days. And it is really challenging to successfully treat a gambling addiction. Because again, you're not buying drugs, you're not having physical health problems, you don't smell like alcohol. You can just be a normal person going through your normal day-to-day life. But especially when you can do it on the phone and just, I mean, it's very bad. It's very bad. So I don't know if that's helpful, but it's definitely a very significant real addiction that is hard to treat.
Yeah, and I don't know, Americans or people from US are looking like a problem addiction that wants to have to be solved, like a cocaine or weed or legalize or, because here in Brazil, gambling is not legal,
Mm.
and the people tend to just do these bets online
Mhm.
because they are legal now, sports betting. And the people the person who asked you this uh, writes in Portuguese that he's seeing a woman patient about 50s and lower income that are showing addiction to gambling
Mhm.
about 2 years, and now she's start to stop gambling, and but now she has a lot of debts, lost trust of her children,
Mhm.
and this impacts the whole existence. And we just when we are talking about addiction, we tend to focus more on drugs or
Mhm.
substance, but we have a really problem ahead, like, because we start to getting everywhere like you said, people don't have to be there to go to a place
Yeah.
to gambling. They can do this on a smartphone and use every money they have, like start to banning.
Mhm.
And you said something, a phrase that the house always win.
Mhm.
That's why you and your family never gambling. I know it's a personal question. You have to answer, but it's I just wanted to ask you this. It's a moral that you guys from Vegas born and raised, like always share with each other, not gambling. Or do you know someone that you go that way that have,
Oh yeah. Yeah, no, I've definitely known people for sure. And I will say, within my family, it was never like necessarily discussed or a big moral thing like we don't gamble, we don't do that. It wasn't necessarily that. It was just kind of like my parents were very down to earth folks. They were, my father worked in the service industry. My mother worked in the service industry and was a homemaker, stayed at home for many years. And it was just like, we didn't have much money. We did not have much money. We were, I won't claim poverty, but we were at the very low end of middle class. And so every dime mattered and we saved. And the thought of spending too much of our money was just never part of it. But I'll give a little nuance. So this wasn't a huge like moral or religious thing. So there's a game called Keno, and it's basically kind of like bingo. And it's very common it's in the casinos, but they also will have, if you go to eat dinner in a casino, you can do it right at your table in the restaurant. And there's a big board with numbers, and you take a little piece of paper and you pick like 7 numbers. and you bet like $5. And then if you get, if you get 5 out of 7, if the numbers on the board come up, it's kind of like bingo. If the numbers on the board come up, if you get 5 out of 7, like you get your money back. And if you get 7 out of 7, you double your money. There's more to it than that, but that's kind of the basic. And when we would go out to breakfast, a lot of times, sometimes we would go out and have breakfast at one of the casinos, and you go to the little restaurant because you get eggs and bacon. And, my parents never played the machines or played the table games. But while we were eating breakfast, like my mom would put like $5 on a Keno ticket. And, maybe a third of the time that would pay for our breakfast. She'd win and we'd get the breakfast, but she never did more than that 5, right? And that was just it. And it was budgeted in. It was just like play money. It's like going and, seeing a movie. It was just a little thing that would do. It wouldn't be every time. So it was kind of, and I knew a lot of people that would mix gambling kind of at that level, almost the same way that someone might just have a couple of beers when on the weekend, and they're not an alcoholic. So the same kind of thing. But yes, I also saw a lot of people very devastated by gambling. I was a waiter in restaurants and casinos for many years before I became a nurse. And I remember very clearly, I had one of my coworkers come in. We worked in the morning, and he sat down and he did not look good. I'm like, what's going on? He hadn't slept all night. We had gotten paid that day. He got our paychecks, and he had his pile of ATM slips, and he could show me. He had sat at a bar, because the gambling machines are right in the bar. He had sat in that bar all night long and just gambled his whole paycheck in one night. And in the morning, and we were waiters, we didn't have money. So that was all his money. He's like, that's my rent money. He goes, I just spent it all. And that's that compulsion thing. And you're like, how can you just sit there and just press a button for 10 hours and all that money that you spent 2 weeks working for is now gone? That's addiction, and that's behaviorism, a big part of it. I think there's a behaviorism aspect of just that intermittent reinforcement, right? You guys are all psychologists. You guys know intermittent reinforcement. It's not that it wins every time. That's not the trick. The trick is you never know. So it can be the next one. It could be the next one. It could be the next one. And you never know when it's going to pay off. And that's the danger of gambling addiction. I mean, if you're taking heroin, you're going to get that feeling pretty much every time you put it in your body. But with gambling, that's one reason I think gambling is so pernicious, is that you just never know. You never know when it's going to pay off. And then there's also an existential part of it, kind of like your colleague mentioned. There's that loss that goes along with it. So now you have this huge sense of loss, there's this emptiness. First of all, is there an emptiness in your life that you're filling with this activity, this reinforcing activity, that you don't have a more positive reinforcing activity to replace it with? Or there's some sort of feeling you're trying to escape. There's some sort of dysphoria that just, playing those cards, pressing that button on the video poker, rolling the dice, feeds that need, that lack. And so you combine that existential level with just, that down and dirty B.F. Skinner intermittent reinforcement, rat hitting a lever to get a pellet. And it's gambling is a very, very powerful addiction, and it's tough to treat. And my hat's off to you if you're treating your patients for this, because it's very complicated. It's very complex. The hardest part is just to get them to recognize and verbalize that it's an issue, because a lot of folks won't. And you really have to say, listen, you've lost your kids, you lost your house, you've lost everything to gambling, and they still won't recognize it. It can be very challenging.
Yeah, it's really challenging. And I'm working in Brazil as a psychologist, a design analyst, and also a supervisor, of other psychologists. And this kind of histories are repeating, and it's good to hear from you that existential analysis is not enough sometimes, you have to be interventional. And I think that we have to talk more about this gambling addiction, because it's spreading it's a really big problem here in Brazil.
Yeah.
Thank you, Anna, for this question. I think that made a lot of comments, but I have another question for you. I don't know if you have any, uh, touch with psychedelic treatment. Like people tend to do this more in the 70s,
Mhm.
but here in Brazil we have what we call ayahuasca. You know
Mhm. Yeah.
ayahuasca, and people used to treat addiction, or any sort of problems, existential problems. They drink ayahuasca, have a vision, and never drink anymore. Or I have heard some histories that way. What's your opinion? Do you know anything about ayahuasca or any psychedelic treatment? On the beginning of the seminar, you told about medical, then moral, and then start to, criminalizing
Mhm.
this this substance that make people feel dizzy, or alcohol, opium, and people here in Brazil call ayahuasca a medicine,
Mhm.
because it has this ritualistic feeling, but it's also a psychedelic, and
Mhm.
I wanted to hear more. What's your opinion?
Yeah, it's a very good question. It's definitely getting in popularity. I don't present myself as an expert on the subject by all means. I know there's some folks that are. I actually have a colleague who's a psychiatric nurse practitioner, um, by the name of Andrew Penn, who's done enormous work on that in the United States at the University of California, San Francisco. He's been involved in a lot of research, so he really is a subject matter on that side. I'm not. Um, I look at it from a few different angles. I think when we look at, again, like ayahuasca, this is a substance that grew up within a very specific cultural heritage with a lot of culture and history and ceremony and expectations surrounding it. So I think the danger is, especially from a Western or US standpoint, is we always want to say, like, oh, we found the magic chemical. Let's just get rid of all the ceremony stuff. That's just making it too much. Let's just take the ayahuasca, and put it in a vending machine. And I'm willing to bet that's not going to be as effective. And I'm willing to bet that a lot of the effectiveness that you do get when you do get it is because it's a journey, right? And yeah, there's a lot of, especially those, that's a big thing about the technology people here in the US, right? There are Silicon Valley, our tech bros that go down to Brazil, South and Central America, and it's a journey, because we don't get a lot of journeys in the modern world anymore. We don't get to go on a journey, on a mission, on a fellowship of the ring, go on an adventure. And it becomes an adventure. We're going to go to this country and we're going to go have this experience. I know it's sort of commercialized at this point too, where they do the whole thing, but you have to fast and you can't eat any meat. And there's like all these rules and ceremonies around it. Then you have this very significant and real psychedelic experience with this powerful substance. And the goal is to emerge from it changed. And I think this goes back to what Jung said, really. It's that higher spirits over lower spirits. So I believe it. I think if you go through a transformational experience, I'm sure there is, in a certain subset of folks, the chance to emerge from that with a completely different view of addiction, and maybe even just leave it completely behind. So I definitely, I honor the traditions from whence that came, and I think there's great potential there for it. And there's many substances. So Timothy Leary, they were initially using LSD for addiction treatment. The Russians, so the Soviets, were using LSD and other substances for treatment of alcoholism in particular. So there is kind of a proud tradition over the past maybe 70, 80 years at this point, maybe going back 100, because there was some use of hashish way back in the early 20th century for these. So it's something that's been looked at, and a lot of the research on it was stopped because of the drug laws. So when this draconian kind of approach to drugs came out that made LSD what we would call a class 1 drug in the US, meaning it's the highest level of illegality. There's no legitimate use. So our drug schedule goes 1, 2, 3, 4, 5. Class 1 are the drugs that our federal government says you cannot prescribe. There's no legitimate research use for it at all, only maybe during research. And so that's heroin is in there. Cannabis was in there it still is a class 1 drug. But we've legalized it at the state level. But LSD is on there, and other of the hallucinogens or the psychedelics are in that list as well. So that has stopped research. So maybe there is a lot of benefit, and we would have known better. We would have had a better idea by now. So that research is being done. That being said, I am very cautious, and this is a good way to get a lot of people mad at you, because you got to be all in on psychedelics. You got to be a cheerleader, or else you get a lot of grief. But I try to be skeptical about everything. And I'm especially skeptical about magic cures, that you take one dose of MDMA and your PTSD is gone forever. You do one ayahuasca trip and your addictions are gone forever. You do ibogaine once and your addictions are gone. So that level of kind of cheerleaderism, I'm wary of, because people get hurt when they do that, and their expectations are not set appropriately. But looking into the possibilities of it and saying, can we systemize that ayahuasca journey to get a robust response? I think it'd be fantastic. I would not oppose that at all. We're using, especially in the US, we're using ketamine a lot. So ketamine is a dissociative anesthetic. It is sort of considered a psychedelic. But we're using it for depression, for addiction, for a whole bunch of things. It's being studied, and it seems to have some benefits, and some forms of it have been taken by the pharmaceutical companies and actually turned into pharmaceutical drugs so they could sell them and make money. And so there's some good work, good research coming out of it. But at the same time, it's definitely a drug of abuse. It can have very negative effects. So we just have to be cautious. And then the folks that get excited about these things, a lot of times they're just people that are excited because they want to help other people. Sometimes it's companies that are making a lot of money by promoting products like this. And so you got to be skeptical. You got to just look at actual clinical research. What happens when you give this medication to patients? What are the positive effects? What are the negative effects? Is it better than what's already out there? Is it so? Yeah. So that's kind of a long answer, but ayahuasca is definitely an interesting thing, and it's I'm totally accept the fact that it can be transformational in some cases. I would also just add that transformational isn't always good. You got to keep that in mind too, that if you're going to change the way you view the universe, hopefully it's in a good way and not in a negative way. And there's going to be not a lot of people. I'm not a panic person. I'm not going to say this is going to drive people, insane. But I'm just going to say, in a tiny, tiny subset of people, you're going to need to adequately screen to make sure it doesn't harm them. A chief example for that for me is cannabis, marijuana. For the majority of people, relatively benign. Not, it's, probably in some ways less dangerous than alcohol. Some ways it's more dangerous, but it is what it is. And the danger with cannabis now is because it's been legalized in the United States in a lot of different areas, there's these very, very potent forms are coming out. So it's been specially grown to have higher levels of THC. But even that aside, so patients will say, yeah, so I smoke marijuana, it helps with my anxiety. There's a small subset of folks, especially folks with schizophrenia, severe bipolar disorder, that cannabis can just be very bad for and cause really negative effects and make their psychosis worse. And they were getting better, and then they use cannabis, and it just sets them really sets them back and can be harmful. And so it's not that cannabis is all good. It's not that it's all bad. It's that you have to really make sure the risk stratification you get for the right people. And that's the same thing I would say about psychedelics. There may be some of us that just shouldn't touch the stuff. And you have to be willing to say, I'm sorry, you see everybody else, you see all your friends going down on an ayahuasca journey, and they're coming back and they're starting a new company and they're brilliant and they're no longer addicted to alcohol. But for you personally, because of these characteristics we've determined in research, you personally should not do this, because I don't think the outcome is going to be good. And that's the point we need to get to.
Yeah, and this brings a question that I write. here in Brazil we have what we call harm reduction policy. You know,
Mhm.
like if people are addicted to cocaine and start to smoke a joint, per day, we see this as a good thing because he's not spending the whole money with cocaine and crack. Uh, he's just doing what become to be sometimes somewhere in the world illegal. Like cannabis and weed. And what you think about this kind of approach of substance users of their treatment, like a harm reduction? Do you see this as a good thing or a bad thing?
Yeah, and this is another great example of clinical research, of the benefit of actually doing research, because we've done research for decades now around the world, and generally speaking, harm reduction is a good thing. Harm reduction helps. So what happens is you get moral arguments and legalistic arguments that come in and say, no, if you make clean needles available for injection drug use, you're just encouraging use. But when you actually look, if you actually do research, you can get the right answers and understand what is good and what is bad. And sometimes, the research might show you, hey, if you do this, you're increasing substance use rates somewhere. And if the research shows that, you need to go with that. Because you can go moral on both sides. There's the moral side that says, no, we should be doing harm reduction. We shouldn't be discriminating against these folks. And you get the moral side that says, no, you're just encouraging this bad behavior. And if you let the research guide you, you can see what works, what doesn't work. And to my knowledge of the research and the literature, which I don't consider myself incredibly well read in, but relatively so because it's my field, from what I've seen, harm reduction tends to be more beneficial than not. The medication treatments I discussed, so methadone and Suboxone, those are examples of harm reduction. Opioid addiction is powerful, and it is really hard to stop. And you can look at, again, research. What are the relapse rates when people stop using opiates with no medications? The relapse rates are incredibly high. You can improve those relapse rates by giving them a medication like methadone, which I don't know how familiar your folks are with it, but what methadone is an opioid, so the same family as morphine, heroin, oxycodone, but it hits the same receptor in the brain, just the same as morphine does, the mu opioid receptor. But it lasts a long time, so it's not a quick on, quick off. It sticks really good, so it kind of locks onto that receptor pretty well. It stays there a long time, and it's a lower level, so you're not getting a big high. But what it does is it kind of, it hits that button all day, so the person is not just sitting there constantly physically craving opioids. It is not sufficient all by itself to treat it. It's not. You can't just give someone methadone and say you're done. You have to include psychotherapy, social support, counseling, all that. But it makes all those things work better because the person is not just physically craving their opioid all day long. So then they can work on the recovery. Suboxone works similarly. It's a little different, but it's the same theory, is you're taking away that physical need for that substance, and then you can work on all those other things that support the addiction. If you get a little more controversial, it's the clean needles idea. Okay, folks are going to inject heroin. Injection is a great way to get hepatitis C, to get HIV, to develop AIDS, other infections. Very dangerous. Very, very dangerous, especially in the era of HIV. So you set up an area in your city where folks can trade in and get clean needles. They're going to go shoot heroin. They're going to go break the law. But you're giving them a fresh, sterile needle. A lot of these places will teach them, here's how you sterilize a needle. Here's how you clean your arm with alcohol. You're kind of teaching people how to safely do that. And from a moral side, even me, there's a certain level where you're kind of like, I don't know. I mean, you're kind of teaching them how to do something bad for themselves. We're saying it's horrible, right? We're saying we need to treat it and stop heroin addiction, but we're also showing them how to do it safer. So it takes a mind shift. It really does. And you look at the research and you're like, well, you know what? You drop HIV rates, you drop hepatitis C rates, that benefits the health of your entire community. And then ideally, you're using some of that time to try to get people into treatment. And I've talked to people that have worked in these centers, and they say, they come in, they get their needles, and you say, hey, you ready to come to a meeting? You want to come to this? And they'll say, no, I just want my needles. You're like, okay, day one, that might not work, but just every day, friendly, open, accepting. How about today? Are you ready to quit today? Are you ready to quit today? Are you ready to go talk to someone today? The hope being that eventually somebody will. So yeah, in general, I would support harm reduction, just mainly because the research shows it helps reduce addiction, and it definitely reduces those secondary issues, the infections and things that can be very devastating.
Would you call this as an existential approach to substance use disorder treatment, like you respecting their freedom and not being that much interventional, and expect them to regain conscience and someday, okay, I want to.
Yeah, exactly. It's very existential. It's public health and existential. You're respecting the freedom of the individual while trying to maintain the general health of your population and your community. So yeah, absolutely.
Sure. Natalia have asked if you have, any sort of paper, book recommendation on the topic. I'm not sure if the topic of the webinar, Natalia, of it's something that he was putting.
I have a great recommendation. I actually know the author. He said it's not available in Portuguese yet. I reached out to him before this meeting because I was like, I want to tell them about your book. He said it's not in Portuguese yet. I think it's in English. It might be, I don't know if it's in Spanish. The book is called The Urge, and it's by Carl Eric Fisher. And I'll double check my spelling of his name. Let's see. It came out a few years ago. So Fisher, I'll just do Carl. Yes, it's called The Urge, Our History of Addiction by Carl Eric Fisher. Probably one of the best books I've read on the subject of addiction in many years. Really good. So he is a psychiatrist who himself struggled with substance use disorder. So the book is partially his, that's it. It's his personal story of his struggles with addiction as a medical student and a medical resident. He had to go through a treatment program. He had to be involved in the programs for physicians that have addictions. But it's also mixed with a big history of addictions, all the way back to, especially kind of focusing on the 18th, 19th, 20th century. A lot of the things I talked about today, the approach to treatment. He's very philosophical. So I really appreciate it because we didn't really get to go into it, but the brain disease model of addiction got really popular in the 90s, like 80s, 90s, especially early 2000s. And the initial hope was that this would reduce stigma, because you'd say, listen, hey, it's not a moral failing. It's not that you're a bad person. It's not that, you're terrible. It's you just like if somebody has diabetes or if they have heart disease, you have addiction, you have a brain disease. It's not your fault. And the thought was, if they could promulgate that idea, that there would be less stigma. People would be more accepting. Oh, don't be, it's not his fault. Well, first of all, that just didn't work. It didn't reduce stigma. People with addictions are still stigmatized. And in some ways, the argument can be made it worse. Because it's like, oh, like you got something wrong with you. You have a disease. There's no point in even talking to you because you can't control yourself. So it kind of flipped it on its head. Existentially, again, it took away the human freedom. And because we always want to balance that line. You want to balance between not saying, I'm blaming you for your addiction. But I personally want to be able to tell someone, you have some control. You're not cursed with a brain disease. And we don't have a treatment for this disease. We don't have a medicine. We have like the methadone and things, but we don't have real medicines. So it's kind of a dirty trick to tell someone they have a disease, but hey, I have no treatment, so you're out of luck. So the disease model is good as far as it goes, where you recognize there are biological aspects of addiction. And those biological aspects can really have a major control over behavior and of choice. So yes, folks that suffer from addiction are very much have a limited choice. They have limited freedom, speaking existentially. Their freedom is constrained. And everything we do, whether it's medicine, therapy, social interventions, 12-step programs, is the goal of expanding that freedom and giving them the freedom back. So anyways, this book talks a lot. He is, he acknowledges, but he criticizes the disease model, and he's a physician. So he's very much in the biomedical model. And, talk again, positive and negative about 12-step programs, where for a long time, the only program you could go to would be a 12-step program, an AA program. In our country, at least, the judge would make somebody go to a 12-step program. Like, okay, you either go to jail or you go to AA. AA is great. It's powerful. It's set on some very core philosophical and spiritual kind of standards, concepts, but it's not for everybody. And that's just, we have to acknowledge that. Some people just don't respond to that model. And for a long time, that wasn't normalized. It's like, if you weren't going to AA, you were in denial. It's kind of like the tricks that we do in psychodynamic therapy, right? Where it's like, well, if you disagree with me, you're in denial, you're repressing. So it's a double bind, because you can never legitimately say you don't like it. So if somebody said they didn't like AA, it'd be like, well, that's your disease talking. That's your alcoholism talking. But that's not the case. That's not fair either. So the book goes into that as well, of saying that, 12-step are great. Some people need an alternative model from the 12-step, and we should research that and develop that and allow that. So yeah, I highly recommend that one.
Thank you.
Great questions too. Thank you so much. I always have to pause and tell my students too, because sometimes my students want to ask questions. And I really appreciate it when folks ask questions, because I do want this to be a discussion. And so you guys are so smart, and you know your culture and you know psychology. And so hearing your thoughts is really very, very gratifying. So thank you.
Yeah, it's been a great webinar. It's a great experience here and now. And yeah, thank you for this on the book of Carl. And I think it's not going to be a problem if people attend to an English webinar. They are probably able to read in English. And I was wondering now, Ron, back 100 years ago, Freud used to prescribe cocaine to his clients, and that's a well-known history.
Yeah.
And now it's it's a big thing, like you don't supposed to prescribe cocaine to your clients in any case. Do you think 100 years from now, people will look at the psychiatric, ways, because people get addiction to medicine as well, do you think that somehow, in your perspective, things are gonna be changed in the future, like looking backwards and say, oh, Ron, you do it all wrong, it's not right to prescribe medicine or anything like this? How do you see these questions? How do you see this?
What I'll say is I hope so. I hope so, because that's the way science is supposed to progress. You're supposed to look back 100 years and pick out the pearls and say most of what they did was kind of going down the wrong alley. So yeah, I absolutely hope so. It's a big problem in psychiatry, especially because we really haven't innovated much. Our most effective psychiatric medications are still the ones from the 50s, 60s, and 70s. So we've come out with a lot more drugs, but these are marketing efforts by the pharmaceutical companies, where the way it works is you constantly have to come out with a new medication in order to keep making money, because medications fall off patent. So you have to come out with something new, or at least a new formulation or something like that. The most effective medications we have in psychiatry are lithium, which has been around since the 70s, which is a salt that you find in the earth, and it's dirt cheap. You cannot patent it. You can't. I know there's some companies working on improved delivery mechanisms so that they can actually patent it, so that it's more of a slow release or whatever. But the medication itself is cheap. the MAOIs, the MAO inhibitors from, you know, the 50s and 60s, the most effective medications for severe melancholic depression. We don't have anything better for severe melancholic depression. Clozapine from the 70s for severe schizophrenia. And really, those are our most effective psychiatric drugs. And so we've been just kind of in this cycle of more of the same for decades now. And so I significantly hope that 100 years in the future, I think our diagnostic approach to psychiatry is improved, because there's a lot to be said about the DSM system and the way that that conceptualizes psychiatric disorders. And I think our medication treatment of psychiatric illness, I would certainly hope is better in 100 years. And yeah, I would love it if they're like, you know, they're looking at us just like, you know, the people that were prescribing, you know, not quite 100, but say 150 years ago in the United States, people were prescribing things like calomel, which is a mercury substance that would cause people's teeth to all fall out. It would make them sick. But it was part of that heroic medicine, they called it. So the bleeding, the leeches, calomel, the things they were doing in medicine back then were just incredibly destructive to people. It didn't really help. It didn't help at all. But they were just, you know, these weren't evil people. They were people that were doing their very best to heal sickness and make people well. But yeah, we've moved along. So I'd be very happy if in 100 years what I'm doing today looks primitive in comparison.
Sure. And when I made these questions to Miles about drugs addiction, the first question that he, you know, like trying to clarifying was to ask, legal drugs or illegal drugs, because medicine can be addiction as well. You know, like we are good people and try to do our best. If someone are watching this 100 years from now, we are not that persons. Yeah. I don't know if anybody has another question. We are approaching the end of this webinar, and it's been great. I don't have any questions, but someone has any questions? Natália, perhaps?
Eu tenho uma pergunta, mas eu não consegui elaborar ela muito bem, assim, então eu acho que eu vou precisar de ajuda. Como ele trabalha com a Daseinsanalyse, né, ele estuda a Daseinsanalyse também, se ele vê esse uso de substância, essa liberdade experimentada pelo uso de substância, como algo também que se aproxima dos sonhos, sabe? Tem uns estudos que relacionam, tipo, LSD com o estado onírico, sabe? Então eu queria, como eu disse, eu não soube montar muito bem essa pergunta, vou precisar de ajuda. Okay, nem sei se faz sentido. Pensa aí se faz sentido.
Yeah, it makes sense. She's formulating a question that she's not so sure that she has accomplished by doing. So she asking in Portuguese, and she was asking, she know that you have a relationship with the science analysis, and when you are on this effects of LSD or any psychedelics, you know, she was asking if you see some resembling between these stages, state of consciousness with dreaming. You know, like we are studying dreams with Tamash, and she was asking if I know that you are not an expert on this, but do you see some resemblance between state of people, mind state of people that are on drugs with dreaming, because people trying to make this not a connection, but they say that they say that it resembles somehow, you know, the experience, dreaming experience and drug experience.
Yeah. Oh no, that's a fun wrap up topic. I like that. That's a good one. Yeah, well, I mean, it was Aldous Huxley who called it the doors of perception, right? He said the doors of perception will open. That's when he was on mescaline. So I would say yes, because we know, if I really wanted to channel Miles, I'd say, what is dreaming? That's answer a question with a question. But it's definitely, we call it an altered state of consciousness. I would think so. And I think some of the benefits that people report from use of psilocybin in magic mushrooms, ayahuasca, DMT, LSD, all of these is, or even so ketamine, the use of ketamine, it puts you into a deep kind of, the doors of perception. That's it. They put you into this deep, very dissociated state where dreaming is a dissociated state to an extent, right? So it is all of a piece. I think it's all of a piece of the just the amazing capabilities of the brain and the places that, or the mind or the brain or whatever you want to call it, the places we can go and the different ways we can experience the world versus the way we experience it in daylight hours, this very real meat-based world. Somewhat of a side comment, but having discussions with folks either who are diagnosed with schizophrenia or have some form of psychosis can be very, very fascinating discussions, especially if they're not in the grips of their illness, deeply paranoid, unable to interact. Once you get folks that are kind of a little bit more able to interact, those can be fascinating discussions about not just hearing voices, but what were you experiencing? Like, what were you hearing? What was the feeling? What did that remind you of or make you think of? And what was that associated with? So for me, it's all of a piece. It's all of these, I won't even call it the mind or the brain, I'll say it the experience. The experiences we can have as human beings, because if one of us has had the experience, any of us can have it theoretically. So dreaming, hallucinatory states. One area I'm particularly fascinated with is what's called hypnagogia. So hypnagogia is when you're just falling asleep, you're getting that sense where you're having these little dreamlike events, but they're not a true dream because it's not the middle of the night. It's just when you're falling asleep. Sometimes people you'll jerk, like you'll feel like you're falling and you'll drink, or you'll start to drift off and you'll hear things and you'll see things. That is a unique liminal space. That's not the same space as dreaming. It's its own unique thing that's been talked about for millennia. You can see people talking about hypnagogia, seeing shapes and images or hearing conversations just as you're falling asleep. And the interesting thing about that state is it's so light, you can actually kind of come back from it. So you can kind of, as you're falling asleep, you can kind of dip down, you can have that experience and actually wake up and think about it. And you can kind of train yourself to do it. This is a good like lunchtime thing. If you just, for a quick 30-minute nap as you drift off to sleep, very common to enter hypnagogia. So yeah, it's these amazing experiences that we can have as human beings, that there's innumerable possibilities of what we can experience. So I think it's all fascinating. So I would say, yes, I think there's something in dreams that is like hallucinations, that is like hypnagogia, that is like even Jung's active imagination. Jung and many others were proponents of an active form of daydreaming where when you do it enough, you're not in control of it consciously anymore. So that active imagination becomes an experience in and of itself. And I think that's a fascinating area of inquiry as well. So yeah, good questions, Natalia.
Good question.
Good questions.
Yeah. So we are approaching the end, and I wanted to thank you, Ron, and everybody for being here today. I know the topics, it's an American perspective or US perspective, but you gave us your perspective and was even greater. And thank you so much for doing this. I don't know if you have anything to add at the end.
No, I would just say my deep, deep, sincere thanks to Roberto for inviting me and for all you attending and for your interaction and your questions. I really admire that. I think and like I said, I'm honored. It was great fun. I'm very much Yes, so I am such a bad Instagram person. I don't even think, I think it's like fully locked down. The only reason I have to admit this, the only reason I go on Instagram is because my wife has a food blog. So I go on to look at her posts when she posts them to Instagram. So I like to look at her food blog, but I'm not too consistent with it. I'm very consistent on LinkedIn. That's kind of been my social platform because just for the professional aspects. So I spend a lot of time on LinkedIn. And I would also say, please don't hesitate if you have any questions or anything, reach out to Roberto. I'm happy, Roberto, you can feel free to give my email to any of the members of your group. Please feel free to reach out. And if you have any questions or comments or anything like that, yeah, please reach out and say hi. I would actually love to hear from folks to see if there's any questions I can answer or anything that this came up, or to learn from you, obviously. This has been a one-way pretty much except for questions, but again, I know you are all established psychologists and professionals. There's so much I could learn from you. So I definitely want it to be a two-way conversation. But yes, my final comment is just thank you. It's been a great pleasure. I love this.
Yeah, we love it as well. Thank you, Ron, for being here. So, yeah, you can call this off, and we'll share your email if you want to have a question. They can ask you directly.
Yes.
And thank you, Ron. Thank you, everybody. Okay.
All right.
Bye bye.
Have a great Saturday.
Have a great Saturday. Bye bye.